I think that the problem is that there is not very great evidence in terms of what the outcomes are for long-term opioid therapy for chronic non-cancer pain. That's not to say that it's good or bad. I think one of the concerns that we may have is that because there is this shift towards all of the bad effects of prescription opioids and all of the overdose deaths that are being attributed to prescription opioids, that there may be a rebound effect where providers are very, very, very conservative in terms of their opioid management. And what we want to impart in our lecture is how do we prescribe opioids, how do we do it safely, and when patients express interest in tapering their opioids, how do we jump on that opportunity and lead them to other therapies that may be more effective?
And we're not necessarily taking a stance in our presentation that opiates are a good thing or a bad thing, but we just want to remind clinicians that, again, it's an interdisciplinary approach that's going to help people the most, especially when you're weaning people off of medications. If the opiates have been the primary tool that they've used to manage their pain, and you're taking that away, you need to give them other tools. And the other tools aren't necessarily other drugs, but other treatment modalities, non-pharmacologic treatment modalities. Some of the challenges that we find with the opioid tapering is, one of the biggest challenges is fear of the patient. They become very reliant on the medications, they become dependent, and dependence isn't the same thing as addiction. And so when people are very psychologically dependent, it's very challenging to get them to accept that there can be another possibility of managing their pain. But that's part of the work that we try to do. We're going to talk during our presentation about an inpatient pain program that we have that's designed to help people successfully wean off of opiate medications. In that program, we wean them using a dosage-blinded pain cocktail, so they're not aware of how fast the changes are occurring. And they're concurrently working with physical therapy, occupational therapy, and psychology to help them develop other tools to manage their pain.
Yes, so a lot of my research has been focused on opioid cessation in more of a perioperative or post-operative environment. I think one of the main factors is motivation and really gauging what the patient finds as motivation for coming off of their opioids. So really understanding what are the risks of staying on these prescription opioids long term. For example, the risk of opioid misuse, overuse, addiction, not to mention tolerance or withdrawal effects. So having the patient have an open dialogue with their provider to place inner goals and to have that at the forefront is really important. I think that when the message comes from the provider in a more punitive message where we say you have to come off of your opioids, that's really not as effective. I think we can learn a lot from our addiction medicine colleagues in terms of this motivational approach and really gauging where patients are along those lines. Once patients find inner motivations and reasons for coming off of their opioids, it's usually fairly self-directed and straightforward, I would say. So I think that the psychological factors as well as the psychological support that we can provide is extremely important in that process. But it is interdisciplinary. It involves medications, it involves any other interventions that the pain specialist could do concurrently, definitely heavily reliant on psychological approaches, frequent contact with patients. All of this is very important. And instilling a sense of self-management and self-care, really having a patient take ownership for their health in general is extremely important to this process. I think that, we have a unique point of view being from a tertiary pain management center. But I also do recognize, speaking with primary care providers out in the community, that it is a serious problem. When doctors retire who have had a different approach, a maybe more liberal approach with opioids, then they're left with re-educating patients. And so our goal is that hopefully some of our message can be mobilized and be adopted by providers in the community. They may be able to refer to tertiary centers like ourselves, or perhaps they themselves can create an interdisciplinary clinic, which with speaking with colleagues out in rural areas, have started to do. They've also gotten buprenorphine waiver licenses for patients with comorbid pain and addiction issues. So I think that spreading the word is extremely important, and I think in a few years the landscape's going to be very different.
I think when you're inheriting a new patient, I think it's a great opportunity for education. The patient has learned one certain way of how to manage their pain with the clinician that they're working with before. And whether it's a primary care provider or a pain specialist who inherits a patient, it's a wonderful opportunity to re-educate the patient, as Jen was saying, on different ways of managing pain. What I always try to instill in the fellows that we teach is that the biggest tool that they have isn't their prescription pad or their knowledge of pharmacology, but it's just themselves as a person. And so just sitting in the room and helping to explain to a patient what's going on, why they're feeling what they're feeling, normalizing it, and not doing it in a punitive way, and helping them to understand why, particularly if they're on high-dose opiate medications, why a different pathway might be more beneficial. I think that's a very appropriate thing.